Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about one 36-year-old male who came to your ER with complaints of outside diagnosed HIV. Sir, so he was a 36-year-old male who came to your ER with the complaints of fever with chills and rigor for about last 1 week. So on initial assessment, the patient was conscious and oriented. Coming to the air was patent and there was no secretions noted. In the breathing, air entry was bilaterally equal and respiratory rate was 20 breaths per minute with the saturation of 100% maintained in room air. Circulation was in BP was 120 over 80 mmHg with pulse rate of 120 per minute. And in disability wise, GCS was E4, V5, M6 with the pupils bilaterally equally reacting. And exposure temperature was afebrile. GRBS was 100 milligram per deciliter. And as he was, history was like this, and we got the history like outside positive HIV. We did an VBG also that time. VBG was normal, no acid base derangement was noted, and lactate was 0.9 with creatinine of 0.98. ECG was showing sinus tachycardia with the heart rate of 108 per minute. And further, we'll move on, sir.
Yes.
In the secondary survey, the history is that he was a known case of bronchial asthma on inhalations SOS. And the history is that he was having some minor fever and he was working outside, not in India, working in Dubai, which he had a routine checkup for visa renewal, wherein which he was found to have HIV positive. Serology testing HIV was positive. And during that days also he was continuing with the fever with chills associated with headache and also productive cough. He also gives a history of watering, redness and itching from the both eyes. And history of for the last 1 week he is also having oral ulcers.
Okay.
And for the same he came to our hospital for further management.
Okay.
And there was no other significant relevant history, no allergic history also. So here we initially itself we took all the blood samples, and along with we also sent for the HIV antibody testing, along with to confirm whether it is the same, and along with it we also sent for the HIV ELISA test also was done, sir.
ELISA is antibody. IgM ELISA.
ELISA.
What is the other test you have to do?
Viral RNA load.
RNA quantitative.
Quantitative
Or qualitative. Qualitative is done for diagnosis. Quantitative is done to know what is the
how much is the viral load.
Okay. But quantitative cannot be used for diagnosis. Quantitative is used only to know what is the number of virus present in the body. Qualitative is done for diagnosis. So here HIV ELISA is already positive. One more test positive means it's positive. Or if you can directly go for HIV RNA PCR qualitative to make a diagnosis. Once you make a diagnosis, you can go for HIV RNA quantitative test. Okay. So infectious mononucleosis like syndromes. These are all mononucleosis like syndromes. Normally IMN like syndrome is seen in Epstein-Barr virus. But it also can be seen in HIV and that type of viruses. Okay, like what is a syndrome? IMN syndrome?
IMN syndrome, patient can have features similar to the AIDS where HIV.
HIV can present IMN like syndrome. Okay, mononucleosis syndrome. That is commonly seen in Epstein-Barr virus. But here also you can see what is a clinical finding
fever,
of
lymphadenopathy.
Fever, rash, lymphadenopathy. Okay, that is a classical. Fever will be there, redness will be there, all over the body rash will be there. Then cervical lymphadenopathy. That is a classical finding you get in IMN. But in HIV also sometimes you can get this type of syndromes, especially in the acute phase. This may not be acute phase, but even then that can be seen. Okay, so how do you proceed this patient? This patient is having a viral fever-like syndrome. He is having HIV positivity. How do you manage that viral fever-like syndrome? How do you manage the HIV?
So initially, sir, we have to, if at all it is not an HIV, look for IgM Epstein-Barr virus also will
EBV, IgM, you
will
have to
send
see.
to rule out the
Okay. Which antibiotic is contraindicated in Epstein-Barr virus?
amoxicillin.
Amoxicillin. And what happens if we start amoxicillin?
Flare up.
They develop a generalized rash. So in most of the viral fevers with lymphadenopathy, when you start amoxicillin, that patients can develop rashes. That is because it's a IMN or Epstein-Barr virus infection. But here in HIV, that can present as IMN, but it is not IMN. Mononucleosis-like syndrome. Okay. So IMN should be ruled out, EBV should be ruled out, then HIV is already positive. Then you are sending a viral load and repeat ELISA to confirm. Suppose it is positive and viral load is very high, or sometimes it can be low also, because acute infection, sometimes it can be very low. Sometimes because of acute infection, the viral load can be very high. So what you will do?
So viral load very high means can be a high infective stage initials.
Viral load high means it is an infective stage. Even in acute phase, it can be highly elevated, or after many years also it can be highly elevated. That doesn't mean that duration we can tell. How do you know the duration of HIV infection?
CD4 count.
CD4 count. What is the normal CD4 count?
500 to 1500 is
Around 500 to 1500. How much viral load, CD4 count can drop in a year?
Like 100 will be.
Around 100 can drop in a year. Around 100 can increase after
Per year.
Because suppose you start treatment after 1 year, the normal expected increase is by 100. Okay. So that is normal phenomenon. So you have to ask for a CD4 count. What is the CD4 count?
Here the CD4 count came out in 95.
95. So in your opinion, how many years infection is having minimum?
Minimum 4 years.
4 to 5 years he has to have infection. So it is not an acute problem, it's a chronic problem. CD4 count has dropped from minimum 500 to now it is 95. So what you do for this patient?
So we have to start with the antiretroviral therapy.
For that you have to see what is the acute infection. So HIV has got two phases. One is a chronic phase whose CD4 count is very low. Other one is an acute phase. Here it is a chronic phase and he has come with an acute problem. It can be an opportunistic infection, it can be non-opportunistic normal viral fever. Whatever it is, you have to wait till the patient recovers from an acute infection to start a ART. Okay. To start ART, you require the primary infection or secondary infection has to come down. Why it is like that? What is immune reconstitution syndrome? Immune reconstitution inflammatory syndrome. What is that? Iris. What is that? So normally when you have an infection, why we get inflammation? Because of your count, normal WBC count, normal CD4 count. Whenever there is an infection like TB or something, you get some inflammation around that. When the cells are very low, you are getting an infection. The inflammatory response is not that good. Okay. Suppose you have tuberculosis, long-term tuberculosis there in HIV patient, and the inflammation is very minimal, mild fever, that's all. But if you start ART, antiretroviral therapy, virus will die and your CD4 count and immunity will increase very fast. So what will happen to the tuberculosis which is already having? There will be acute inflammation against that infection, that is called as IRIS. Okay, immune reconstitution inflammatory syndrome. Immunity has come back. So suddenly this immunity will act against the bacteria which is producing problem. Okay. So whenever there is an acute problem, you have to treat that first. Okay, once that patient is recovered from all that or partially recovered from that, or you are able to control with your drug, then you can add ART. So now it is a viral fever. Okay. So you have to wait till the viral fever finishes its normal course. Okay. So you give antipyretic. If secondary infections are antibiotic can be given. Oral candidiasis is there. That should be treated. What is a treatment for oral candidiasis?
Oral candid mouth pain can be given along with the fluconazole tablets.
What is the dose difference between a normal person to HIV patient in fluconazole? It's almost double. Normally we give 150 milligram to 200 milligram once daily. Here minimum 400 milligram we give. That is the main difference. So you can start fluconazole tablet for this patient. That can be continued. And viral fever treatment also can be given. What determines the ART? When we will start ART in HIV?
Once he becomes
That is only once the infection is over, we have to start, irrespective of his CD4 count, irrespective of his viral load. If it is positive for HIV, if there is no opportunistic infection at present, we can start ART. Okay. So, how do you start ART? We will not discuss the details of ART, but it's a combination of
combination
drugs.
drug.
Okay. What are the common combinations given nowadays?
One like tenofovir with emtricitabine and dolutegravir.
That is the most commonly used regime. Tenofovir, emtricitabine, and dolutegravir. We should know what are the side effects it can. That's a chronic drug you start for any patient. They'll be taking lifelong. We should know as a ER physician, we should know some adverse effects of all these drugs. What adverse effect it can produce?
Hepatic.
Normally, these drugs will not produce any problem. This tenofovir and lamivudine, all these things can produce pancreatitis. That is the only thing a patient come to emergency room that can produce sometimes pancreatitis. Some patients can come with metabolic acidosis. Lactic acidosis is also common. But they are all clinically insignificant. Pancreatitis can be sometimes painful in patients. That lactic acidosis will be clinically insignificant. Lactate will be high. Patient can have some acidosis. That doesn't mean that patient will be bad. Okay. So they are the common side effects. Otherwise, there are no major side effects for tenofovir, emtricitabine, and dolutegravir. So that can be started. Then what do you do for this patient?
So here he had a lower respiratory infection. So we started with the IV antibiotics along with it.
What antibiotics? Suppose you have a patient who is having lower respiratory tract infection in HIV patient whose CD4 count is less than 200. What are the dangerous respiratory infections? Common respiratory infection, we know that streptococci can be there, some virus can be there, H1N1 can be there, COVID can be there. But what is the dangerous organism which can produce problem in a HIV patient whose CD4 count is less than 200?
Pneumocystis jirovecii.
Pneumocystis carinii or pneumocystis jirovecii. What treatment can be given for that? How is the presentation pneumocystis carinii pneumonia?
Fever with
fever, cough,
and
breathlessness, hypoxemia. That is very important. Hypoxemia. Most of the time, chest signs may not be there. X-ray may be normal, but after some few days, severe bilateral crepitation, bilateral diffuse infiltration in the chest X-ray can be there. Severe hypoxemia can be there. Where is the pneumonia here? In the it is which type of pneumonia it is? Anatomically, which type of pneumonia? You can have a lobar pneumonia, you can have a interstitial pneumonia, you can have a bronchopneumonia. What type of pneumonia it is?
Interstitial.
Mostly it is an interstitial type of pneumonia. So that's why severe hypoxemia can be there. But many patients also can have fungal pneumonia associated with this type of problem. Whatever it is, we give, what is the drug of choice? Cotrimoxazole, Bactrim DS, 2 tablets, TID for 21 days. If the patient having severe hypoxemia, what else you can give? Steroids. Steroids can be used even when the CD4 count is very low. If the patient is having severe hypoxemia because of PCP pneumonia, you can give steroids. Okay, you can give a tapering dose over 21 days. So that also should be given. But whatever it is, after treating after finishing the treatment for PCP only, we can start ART. Otherwise, it can produce immune reconstitution syndrome. What are the components of immune reconstitution syndrome? Components means how do they present? They present high degree fever. They present with lymphadenopathy. They present with severe cough, breathlessness, pneumonia-like features. Suppose it's a PCP pneumonia. Unknowingly, you started ART. Or PCP or tuberculosis, you started ART. So there will be severe reactions all over the body. There will be severe lymphadenopathy, mediastinal lymphadenopathy, breathing difficulty. All these things can be there. So to avoid that, you have to treat the secondary problem first, not primary problem. Secondary problem is opportunistic infection. Then treat the primary problem, that is HIV. So that has to be done. Okay, that is very important. What happened to the patient afterwards?
Here itself, we initially treated with the IV antibiotics and also
The
chest X-ray
antibiotic
was
is this Bactrim DS.
Bactrim DS. Initial chest X-ray was normal. To rule out any pneumocystis, we did a CT also.
Okay.
CT was also fine, but we started with the Bactrim DS and also along with it, conjunctivitis was also there. So antibiotic eye drops were started and also oral candidiasis for that fluconazole and candid mouth pain was given.
How long you have to continue Bactrim DS?
21 days.
That is for PCP treatment. Then you have to give secondary prophylaxis or if there is no PCP, you have to give primary prophylaxis. After treating PCP, then you have to give secondary prophylaxis. How long we have to continue? Continuation is for more than 6 months after CD4 count become 200. So we have to wait for 200 CD4 count, then another additional 6 months we have to give. So that is very important. Otherwise it can come back. So that is a treatment. Anything else?
And nebulization also were given and he became okay like 1 to 2 days.
Pentamidine nebulization is advised in the PCP pneumonia, but it is not available in our country. Okay.
And when he become better, we started with
If the patient goes to on ventilator, what are the common complications it can produce?
ARDS.
ARDS it's a type of ARDS. Non-cardiogenic pulmonary edema feature will be there in PCP. What is a complication when the patient is on ventilator with PCP? Pneumocystis carinii. What is a common complication?
Pneumothorax.
Pneumothorax. So barotrauma is very common. They can develop pneumothorax. So increasing people like other conditions like your ARDS should be very carefully done. These patients can develop pneumothorax very fast. One of the common complications. Okay. So that you have to be very careful. Okay. Thank you.